Hello, this is Dr. Kassabian. I'm a urologist, and today I will do an update on men's health with a focus on prostate cancer, specifically screening and treatment. I have no financial disclosures or conflicts of interest with the material in this presentation. So we'll start with the anatomy of the genitourinary system, and we know the prostate is located between the bladder and the penile urethra, and it's a reproductive organ and a sexual organ as well. So prostate cancer is the most common non-skin cancer in men. However, it's not the deadliest. It's the second leading cause of cancer death in the United States. And only about 25% of prostate cancers are thought to be clinically significant. This is a representation. It's about 27% of all newly diagnosed cancers are prostate cancer, although you will note that lung cancer is much more, has a much higher mortality rate than the prostate cancer. And this is the trends for cancer by sex in the United States. And you could see with the beginning of the PSA era, you could see a very large spike in the incidence of prostate cancer. And this led to the question, are all of these prostate cancers that we're diagnosing need to be treated? And the overall death rate you're seeing also for prostate cancer has also held steady and also come down as we're diagnosing more of them, although we're diagnosing more of the maybe less clinically significant prostate cancers that are being treated anyway. And the lifetime risk of developing prostate cancer is about 1 in 6 from birth to death. And the risk of dying from prostate cancer is 3%. However, once metastatic disease develops, there is no cure. And prior to the PSA screening era, which is in the 1970s and 80s, there was only 25% of prostate cancer presented that were confined to the prostate versus 91% since then. So we're catching these a lot earlier. And the 5-year cancer-specific survival rate increased from 70 to nearly 100% in the early 2000s. As we know, most patients are asymptomatic. They're diagnosed due to an elevated PSA or an abnormal digital rectal exam. Advanced cancer may present with bone pain, weight loss, hematuria, retention, hydronephrosis, lower extremity weakness, as well as difficulty with ambulation. The main risk factors are age, which is the #1 risk factor. Even in cadaveric studies, about 80 to 90% of men over the age of 85 have prostate cancer on cadaveric examination. As well as family history, particularly first degree, much higher rate, as well as being of African American race. There was a trial, the PCPT trial. This was a famous trial with 18,000 men randomized to placebo versus Proscar 5 milligram. We had a 7-year follow-up, and it did decrease the risk of prostate cancer by 25%. However, in the initial analysis, there was a small increase in high-grade cancer development, which is why the usage of Proscar or finasteride never took off for this indication. However, even though afterwards they did some more analysis and they showed that the increase in high-grade cancer development was not true. However, the initial observations did stay with people. The REDUCE trial was also a similar trial using dutasteride, and this was 8,000 men and a follow-up of 4 years. Again, this also developed the risk of developing Gleason 6 cancer, and 5 was decreased by 27%. However, in this study, in the beginning, it did not show an increased risk of developing high-grade cancer. So the main question, even at that point, and even now, and continues to today, is the question about screening. And should we screen at all? What age should you stop screening? And some advocate that an age of 75 should be utilized as a cutoff for screening. And AUA guidelines, which is the American Urologic Association, state and NCCN guidelines state that screening should be individualized based on overall health. specifically life expectancy more than 10 years, family history of longevity, and minimal competing medical comorbidities. So based on different groups, the age to start screening has differed, either 40 or 50, and usually it's PSA and the DRE. However, we're slowly going transitioning to an era where the PSA is preeminent along with other adjunctive tests with the PSA. Memorial Sloan Kettering guidelines, they said begin PSA screening at age 45. And for men 45 to 59, they even said use a cutoff of 3 instead of 4. And then based on if the PSA was very low, you could even screen them later, even 5 years. And for patients 60 to 70, similar. If the PSA is less than 1 in a patient 60 to 70, they recommended no further screening. And for MSK in the 2010 guidelines, they did not recommend screening anyone over the age of 71. So screening is controversial, and we have to understand this PSA-based screening lead to decrease in the risk of death for prostate cancer. And the answer for that would be it depends on how aggressive we are with the lower risk cancers. And the advantages are that it may prolong survival rates and save lives. However, it can also save men from long, painful death with little effective treatments available, including we have to think about the costs. The main disadvantage is the overdiagnosis issue, which leads to overtreatment along with all the side effects from the treatments, as well as a potential decrease in quality of life, including erectile dysfunction and urinary issues from treatment, along with the concomitant costs. So this was a paper, lead time and overdiagnosis in prostate cancer antigen screening. This was in the New England Journal in 2012, looking at the quality of life. So they determined that of all screen-detected cancers, an estimated 10 to 56% would not have become apparent or cause symptoms. And the lead time for diagnosis is estimated at 5 to 12 years. So remember, in 2010, the USPSTF downgraded PSA screening from inconclusive to D, as in don't do it. And this was done on a meta-analysis of all the available literature at the time. So they said after about 10 years, PSA-based screening results in small or no reduction in prostate cancer specific mortality and is associated with harms related to subsequent evaluation and treatments, some of which may be unnecessary. So this was the US Preventive Task Force Services. So, and what is wrong with this recommendation? It was that at the time, the European randomized trials had not reached its primary endpoint, and they inappropriately included very different trials in the meta-analysis. There was a lack of appreciation for the strong relationship between PSA and the prostate cancer mortality, and inadequate consideration of time to event. So there was a long delay between elevated PSA and death from prostate cancer, as well as overall mortality may not be the appropriate endpoint. And the mortality risk of surgery was exaggerated at 0.5%, which generally it's lower than that. So in terms of screening, there's 2 large trials done recently looking at survival benefit from screening. There was the PLCO screening trial, as well as the ERSPC screening trial. And these 2 randomized control studies are largely the basis for the US PSTF recommendations. So PLCO trial, which was a US trial, was 76,000 men, 55 to 74. And they found that after 7 years of risk, 7 years risk of death was the same. However, there were flaws in the methodology, which makes these conclusions questionable, but they found no survival benefit for PSA-based screening. And this was at 13 years, they found 158 prostate cancer deaths in the screening group and 145 in the control group. So the issue with the PLCO trial was there a significance of screening in the control group. So it wasn't really a control group, it's up to 50% contamination, which means, this was very high level of contamination. And there was a relatively low rate of biopsy in men who had abnormal screening results in screen arm. So less than 50% of men in screened arm with indication had biopsy done. And there was a short follow-up, less than 10 years. There was also the ERSPC screening trial, which was 182,000 men were randomized. And this was age 50 to 74 included. And median follow-up of 9 years, there was a 20% reduction in prostate cancer deaths in the screen group. And there was a 41% reduction in metastatic disease at presentation. So at 11 years, there were 299 prostate cancer deaths in the screening group and 462 in the control group. And the rate ratio is 0.79. So the ERSPC screening trial, there were numerous sites of trial entry, 7 countries. Mortality reduction of 20% came with large investment. And to prevent one cancer death, need over 1,400 men to be screened over a decade, and 48 men would require treatment. So problems with both studies, there was a short follow-up, which was less than 10 years. And as we know, mortality from prostate cancer in general, especially in the lower or even intermediate risk group, is very low in the first 10 years. And subset analysis was not done for high-risk men, i.e. those with family history, African American. For the Goldberg screening trial, randomized population-based prostate screening trial, there were 20,000 men randomized, age 50 to 64 included. Median was 56. A median follow-up was 14 years, and found a 44% risk reduction in prostate cancer-specific death in the screen group. So, and this found that in 293 men needed to be screened, and 12 men needed to be diagnosed in order to prevent one death. So mortality results from the Goldberg randomized population-based screening trial. As you can see, the control group versus the screening group. And this is the cumulative risk of death using the Nelson-Allen cumulative hazard estimates. So over 14 years, the PSA testing increased the number of cancers detected by 50%, but reduced the risk of dying of prostate by 44% in all men and 56% in screen men. So overall, although there's a wide range of data, the screening overall does help in preventing prostate cancer deaths, although you may need to screen a lot of people to prevent one death. So the diagnosis of prostate cancer. So I just wanted to review the PSA, which is a protein serine antigen, which is the type of protein made by the prostate, can be elevated anytime the prostate is irritated, which could be secondary to BPH, prostatitis, recent ejaculation, prostatic trauma, which is by massage, biopsy, instrumentation, cycling, etc. And the PSA should be adjusted for age and ethnicity. You can see between 40 to 49, the 2.5 can be the cutoff. And over 70, we can go up to 6.5 or even, and definitely over the age of 80, you can use a cutoff of 6.5 or even slightly higher. So PSA is not perfect and can only be used to define the risk of prostate cancer, but not the diagnosis. There's no universally accepted threshold value, and decision to biopsy based on many different criteria, which is the age, the health, PSA velocity, which is the change in PSA over time, PSA density, which is PSA divided by prostate volume, and the higher the value, the higher the risk. Usually some people use a cutoff of 0.1 or 0.15, as well as family history and race. So this is the estimated prevalence of PSA screening by year and age. As you can see, the highest rates of screening are between 65 to 75 years of age, up to 79. And we do notice that in the year 2005, there was a big increase in screening the patients between 80 and 84, which we can discuss. It's in a gray zone if to screen over 75. So important to note that there is a PSA variability. So in a given individual, levels may vary over time by over 30%, which is why in many cases, if one PSA is elevated, generally I will give antibiotic or some type of treatment, get a history, and then repeat the PSA in 6 to 8 weeks, and even do a trend analysis over 6 months, especially if the patient is resistant to any type of biopsy, or if they have multiple comorbidities, if they have to stop anticoagulation. We could follow the trend and see what happens. And this is one study in JAMA from 2003, and we could see that, for example, they saw that if the PSA was greater than 4, which happened in 21% of the patients in this study, 44% of these patients returned to normal, and in 80% of those cases remain normal. So that's very important to know that 80%, so about half these patients almost, the PSA went back to normal, and majority stayed that way. And similar values we could see for free PSA, with PSA 4 to 10, where a higher free PSA level would be better in terms of a benign disease, and a low free PSA would guide us towards doing a biopsy. So this is very important to note, that one abnormal PSA doesn't tell you the whole story. So definitely it makes sense to repeat the PSA. So indications for prostate biopsy included suspicious DRE, of course, age, ethnicity, family history, as well as abnormal total PSA, as well as if we see a rising trend of the PSA despite treatment with antibiotics. So important to know that although we think of prostate biopsy as a benign procedure, and majority of the time it does have a hospitalization rate. For Medicare data, it's almost 7%, the 30-day hospitalization rate, and including infection, bleeding, urinary obstruction, and there is even a 30-day mortality rate of up to 0.31%, mostly from sepsis. So important to note, and generally make sure patients are treated, check their points for it, make sure they're drained. Very important that we treat these with the appropriate antibiotics during the biopsy, and sometimes afterwards, depending on the analysis. So, so when to perform imaging. So not every prostate cancer patient has to have imaging studies. Bone scan if the PSA is over 20, Gleason of 8, which is high grade disease, bone pain, and a CT MRI if there's a PSA greater than 20 or a Gleason greater than 8, or of course if they elected to undergo some type of treatment such as radiation treatment, of course they would get the CT scan during that process. And so so as we could see, if the PSA is greater than 20, there's a 16% chance of a positive bone scan versus 5 or 2% if it's 10 to 20 or less than 10. And if the PSA is greater than 50, you have over 1/3 of patients have metastatic disease. And same if the Gleason score is 7 or less, it's 5% chance of positive bone scan or metastatic disease versus almost 1/3 of patients with Gleason 8 have some kind of metastatic deposit on the bone scan. So PET CT, this is of course routinely used now, and much better images compared to the past, and able to follow these patients and metastatic deposits and see any response to treatments. So let's talk a little about the risk criteria. What is risk? So risk is based on several things, which is the PSA, of course, the DRE, and the majority, a big factor in is the Gleason score, which is a pathologic score based on looking at the slides when they give a major score and a minor score based on the appearance of the glands and how disorganized they are. 5 meaning very disorganized, 1 meaning very organized, well differentiated. So and number of positive biopsies, of course, out of usually we do 12 cores, 6 on each side. So low risk is when there's a PSA of less than 10, as well as a Gleason score of 6 or less. Intermediate risk would be a PSA of 10 to 20. PSA 10 to 20, along with the or Gleason of 7. However, intermediate risk would also be Gleason 6 with a PSA over 10, which means there may be some other things going on in that prostate. High risk is PSA greater than 20 or a Gleason of 8 to 10, makes automatically a high-risk candidate patient. So the treatment options are active surveillance, which has been increasing and taking off, which was in Europe a lot more 10, 15 years ago and has been coming here the last 5 to 10 years. Surgery, radiation, in some places cryoablation. So active surveillance. It's not discussed enough in this country, although that is changing. And the criteria were more strict before, are still pretty strict, and it's individualized. But if you have a low-risk patient, which is organ confined or a T2A, PSA of less than 10, life expectancy less than 10 years, and a Gleason of 6 or less, this is a inclusion criteria, as well as very low risk, which is that patient, as well as if there's less than 3 cores, along with less than 50% of each core involved, such as a patient with a Gleason 6, PSA of 7 with 1 core, with 10% of that core with prostate cancer would be very low risk. Cryoablation it's performed in some areas, and although not as much as before with the onset of robotics, there is some good salvage option, especially for men with recurrent disease after radiation or brachytherapy. Cryoablation is a good option for that. They do have a significant ED after treatment. So radiation, there's the external beam radiotherapy, which is whole pelvis, conformal or IMRT, as well as brachytherapy, which is radioactive seeds implantation, which used to be more common before, although there's been a transition more towards external beam radiation treatment over the last 5 to 10 years. And the downside with the brachytherapy is there's a permanent low dose rate. So if you have small children, they can't sit on your lap for a while. And so going towards external. So for low risk disease, IMRT or brachytherapy are good treatment options for a curative approach, and no need to add ADT. For intermediate risk disease like Gleason 7 or PSA 10 to 20, you can do 2 months before, during, and 6 months after, 9 months to 1 year total of androgen deprivation therapy. And for high risk disease, you could add longer course of ADD up to 3 years, which is hormonal ablation treatment. There was a BOLA study that showed in the New England that just before, during, and 3 years of after radiation therapy. And so the next treatment option for the prostate cancer would be open, which is not performed as often, although that is a valid option. Pure laparoscopic, which depends on when the training happened, they would be able to do that. Or the most common now is the robotic assisted laparoscopic radical prostatectomy, and which uses wristed instruments with 7 degrees of freedom and great visualization to be able to, especially makes a difference for blood loss and the reanastomosis, so that you prevent urinary continence and bladder neck contractures. Surgery is the only form of treatment with a randomized trial, which did reveal cancer-specific and overall survival advantage when compared to surveillance. And survival benefit was seen primarily for men less than 65 years of age. And authors of that study revealed an updated 15-year follow-up, and they again found that there was an cancer-specific as well as overall survival benefit for men undergoing surgery versus surveillance, especially less than 65 years of age. I just wanted to go over this study from the New England Journal, which was referencing radical prostatectomy or watchful waiting in early prostate cancer. This was a trial out of Sweden, and this found that the number of men younger than 65 needed to treat to prevent 1 death is now 4. So 4 instead of, as we saw before, 12. Because of the longer follow-up, you saw the difference in effect. So, and this was the the two arms, the radical prostatectomy arms versus the watchful waiting arm, is, as we could see, the proportion of survivor, depending on if they have androgen deprivation treatment, is visualized here. And we could see that in less than 65, there was a much greater survival benefit, and that carried all the way to 18 years. Although there was also a survival benefit in the over 65 age as well, in compared to the radical prostatectomy arm on the left versus the watchful waiting arm on the right. So this is a very important study that revealed the benefit of surgery compared to active surveillance, particularly for the less than 65-year-old. And the life expectancy is very important in these instances. That's a major factor in guiding them into surgical or watchful waiting, active surveillance. So in this study, that you could see that death from any cause, the radical, the watchful waiting arm was higher, although we have to go out to 15 years, 10 to 12 to 15 years to see the difference, as well as we can see cancer-specific survival rate was improved in the radical prostatectomy arm. And as you can see, the hazard rate was 0.75, reduced to death from any cause. Death from prostate cancer, the hazard rate was 0.62, and metastatic disease 0.59 compared to watchful waiting. So the takeaway from this, especially in young men or men younger than 65, that the radical prostatectomy does give a survival benefit overall and for prostate cancer as well as dramatically reduce the risk of progression and the need for hormonal therapy, which affects the quality of life a great deal. So there's a lot of benefits to surgery in this cohort. So just a few words about the pivot. It was a randomized men less than 75 years to radical prostatectomy versus expected management. So 731 men were studied. Follow-up was 10 years. And so this was different than the Scandinavian trial in that we're now in the PSA screening era. And there was when we looked at the patients with the PSA greater than 10 or a high risk, then we see that there is a significant improvement with treatment versus observation. Less so overall. So 6%, 5.8% of the men who had surgery died from prostate cancer versus 8.4% in the observation arm. So essentially, there was no difference between the groups. However, the main takeaway from this study was that the patients who benefited were the patients with PSA greater than 10 and intermediate and high risk tumors. So, which is why the selection of the patient, A, for the biopsy and B, after biopsy for treatment is very important. You have to have an informed discussion so that you don't over-treat those patients with the low-risk disease. However, intermediate, high-risk PSA greater than 10, I would definitely advocate for a treatment option, especially if they're under 65. PROTECT trial opened 2001, closed 2008. This was 111,000 men and ongoing. And this was the blood study. This was results of a long-term follow-up. This was a large active surveillance cohort with localized prostate cancer. And we could see that as you progress, the risk of non-prostate cancer deaths is much higher, which means that a majority of these patients died with prostate cancer, but not of prostate cancer. And that's why we don't want to intervene in those cases as well. So this is where we get into the art of urology or the art of medicine instead of the pure science. And it is individualized in a lot of cases. You have to look at the entire patient, particularly their life expectancy and quality of life is probably one of the biggest factors, in addition to the type of cancer it is. So the question is PSA screening for prostate cancer dead? And is there anything better? So we can screen more effectively, keeping the mortality rate from prostate cancer low without harming a large number of men by screening smarter. So risk adjusting the frequency of testing and repeating the test of an elevated level after 6 to 12 weeks. And also, personally, I would follow the PSA trend for a while and see, and that will be one way of following without doing the biopsy, seeing, because we saw that a lot of these PSAs go back to normal and stay normal. So I think that's very important not to get too caught up in doing a biopsy right away after one abnormal PSA, especially if it's below 4 to 10, if it's between 4 and 10, the PSA. Using more specific panels of markers, and there's many of these. However, personally, I like the concept of the PSA velocity. That gives me a lot of information, as well as PSA density, using an ultrasound to get the volume of the prostate, and then getting the PSA and dividing it and seeing if it's a very high number. For example, if the PSA is 5, but the prostate is 20 grams, that would be 0.25. That's a very high PSA density. I'd be more inclined to biopsy that patient. A higher PSA in a very small prostate. But if the PSA is 6 and the prostate gland is 150 grams, then that's likely someone we could follow the PSA. So that's a key point, the PSA density, as well as the PSA trend, the velocity. Although there are a lot of specific panels of markers, there's many companies offering that, although for me, using the PSA velocity, the trend, and the density gives enough information. And then expanding active surveillance for low-risk cancers, this is critical, not to overtreat, especially if they're over 65 and they have multiple comorbidities. Life expectancy might be 5 to 10 years. I would not advocate for treatment of a low-risk cancer in that age group and that patient. So in conclusion, prostate cancer is a very common problem, and we need to know which men to offer screening, when to begin and end, and how often to offer screening. Currently, we are overdiagnosing the prostate cancer itself, which leads to overtreatment of prostate cancer in the United States, particularly low-risk disease, although this is improving, and I feel like it's been improving every year, where we are selecting more of the patients into the active surveillance. And we desperately need to find better ways to delineate aggressive forms of prostate cancers from the indolent disease and the disease that you'll die with instead of from, in order to offer treatment to men who will benefit and critically spare those who will not, to spare them the risk of this treatments, including erectile dysfunction, urinary issues, and other side effects of surgery and radiation. Thank you.